Hormones affect females of all ages. Neuropsychiatrist Dr. Saad Shakir will explain how and in what way. I'm Marilyn Priel. Stay with us to learn all about it. Dr. Shakir is a neuropsychiatrist trained in many areas of medicine. He is the CEO of Silicon Valley TMS with multiple offices in the Bay Area. It's nice to have you back again.
It's very nice to be back. Thank you, Marilyn.
Well, we ladies and the crew are very happy to have you come and talk to us about female hormones. And why do they affect emotions so strongly?
That's a great question, but I do hope in your audience the men are watching too, because I'm going to give them some good insights.
Well, do women have more anxiety and mental disorders than men?
So let me expand on that question. If you look at development, in childhood there's not much difference in terms of emotional reactivity. But around puberty, the female hormones develop, particularly estrogen and progesterone and testosterone, produced by the ovary. The research in the past 2-3 decades shows there's a connection between the female hormones and the neurotransmitters, which are the chemical messengers in the nervous system, which is why a neuropsychiatrist is talking to you about women's health, because we see a very close connection. For example, we all know about serotonin and norepinephrine and dopamine. Perhaps you remember from my previous talks on depression and anxiety. But estrogen is a precursor for those hormones. So when you have fluctuations in hormones, you can have fluctuations in the chemical transmission in the circuits of the nervous system. And let me outline, that's not just in the brain, but in the body. For example, the intestine. Sometimes intestinal symptoms can happen, headaches, pain. So there's a very close connection between hormones and the mood receptors.
So how do the other hormones in the body, say serotonin, how do they interact with the estrogen? If you have not enough or too much, say, of serotonin or other hormones, does that affect how the estrogen works in the body?
If I may give you a little bit of a verbal description of the connection. So if you have the nervous system, there's a part of the brain called the hypothalamus. We often know in medicine there's what's called an HPA axis. Hypothalamus affects the pituitary, affects the adrenal gland, affects the gonadal hormones. So in women, gonadal hormones are what's produced in the ovary primarily. So any fluctuations from the higher level of the brain to the lower level can affect the circuits in transmission with mood, anxiety. For example, a common example is stress. Stress hormone, or cortisol, can have an effect on menstrual cycle. We all know that practically. Now we know the science behind it, because it all talks to each other. There are feedback circuits between the HPA axis and the gonadal hormones. For example, PMS is another example. When there is a drop before the menstrual cycle in estrogen and progesterone level, that triggers mood symptoms, irritability, anxiety, but also sometimes physical symptoms like bloating, irritability, headaches, food cravings, weight gain. All of these are related. So they are receptors that are impacted by hormones. And the stress or the nervous system hormones have a major impact on the whole nervous system.
Now, do women vary in the extent that they're affected emotionally?
For sure. So let me walk you through that. So if you look at pre-puberty, there's not a whole lot of difference other than how girls and boys are brought up. But if you look at puberty, a lot of the changes that happen in a girl's body is maturation of the ovary. When the ovary matures, it starts producing more estrogen and progesterone, primarily, to some degree other hormones like testosterone. But those affect the development of the female characteristics, including puberty characteristics, including preparing the uterus to have the first period. It's at those times when the hormones are abundant that you notice also more moodiness likelihood. So for example, if a girl has inherited a gene for depression or anxiety, even though she's had it all of her life, it's the fueling of the hormonal changes. So oftentimes it's not hormones or no hormones, it's shifts in hormones that make major changes when it comes to moodiness. So that's why we sometimes feel, this teenage girl is acting moody in a more moody way. Before she was the best child, so to speak. Now she's more moody, more irritable. So that's the effect of hormone. So if you go through the life cycle, then you have, when the first few years, sometimes a girl doesn't have regular menses because the hormones are not fully mature. When they do become more mature, then she has regular persistent cycles. And a lot of young women do have a premenstrual syndrome or premenstrual moodiness, which is, I can talk about that maybe later on, because the hormones through the cycle shift. Then in the event there's a pregnancy, that also is another major shift. Then the postpartum period. So those periods are major shifts in hormones. And then later on in life, you have perimenopause, which is the transition from normal menstruation to menopause. And then you have postmenopausal. So each of these phases associated with shifts in hormones and certain syndromes or experiences that women go through.
Well, I just wanted to ask you a little bit more about the young girls. So what I picked up from that is if you have a depression in your gene, you might be a woman or a girl who would have more emotional problems during that yin-yang of the hormones around the period. Is that what you're saying?
So you picked up that, but let me also clarify. Not only girls who are going to have anxiety and depression notice a shift. Everybody notices a shift. But those who have more severe tendencies start manifesting more severe symptoms. But every teenage girl does go through moodiness because of the hormonal fluctuations.
Having a lot of girls and boys and my children and grandchildren, I have noticed a difference between the girls during that puberty area and the boys. More angst and a little more touchy. But I thought maybe boys are just more keep things to themselves, but it actually is the hormones then for the most part.
Well, hormones is definitely one component, so let me not make it too simplified, but as we're discussing hormones, let me focus on that. So the sensitivity, the irritability, the moodiness are definitely more linked with the hormones. However, boys are not off the hook, because if you look at aggressive behavior, it's related to testosterone, which are produced in the testicles. But our topic today is women's health. But boys get into more competitiveness, more combativeness, more irritability, more anger because of the male hormone testosterone. The sensitivity is mostly related to the estrogen, progesterone in girls.
Just real quick too, what about the little girls who begin puberty really early, like say 10 years old? Does that have to do with hormones, or is it something more physically in the body?
Well, it's scary. So this, let me again back up a little bit. If you look at the effect of commercialism and pesticides and diet and steroids and the way animals are fed, all of those are affecting unnaturally how girls grow, and boys to the degree. So sometimes premature puberty is related to maybe the kind of milk
hormones
they had,
milk.
or the meat they ate through childhood, if it was all. That's why we sometimes in integrated medicine advocate organic, advocate more natural stuff, where you minimize the effect of pesticides and artificial ingredients that can wreak havoc in hormonal development. Because sometimes a girl is 9 years old and she's physically maybe developed, but she's emotionally very immature. And then there's all the psychosocial issues with bullying and premature development. So it's not good to affect normal nature. And unfortunately, sometimes people grow up in inner cities where that's happening a lot.
Well, let's talk about the pregnancy then. We've talked about PMS and puberty. Let's talk about what happens when a woman becomes pregnant. they sometimes get that nesting feeling. Is that part of the hormone, or is it just part of being female?
Well, let me also say there are many wonderful things about being female, but as we're talking about pregnancy and we have limited time, let me focus on that question. So what happens in pregnancy? Well, we know the physiology of a sperm and an egg and fertilized egg. Once the egg is fertilized, then there is a production of a hormone called human gonadotrophic hormone, HGH. When we do a pregnancy test, we're actually measuring HGH. So that goes up very quickly, as early as 8 days after conception. So that's why some of the sensitive pregnancy tests can show positive early on. That starts making a lot of physiological changes in a woman's body. The first few weeks, it's produced by an area in the ovary called corpus luteum, which is the one that produces HGH. Later on, it's produced by the placenta. The placenta is the tissue that the baby grows in. So that makes major changes in the size of the uterus growing, the muscles relaxing. Progesterone hormone is very important for the early phase of pregnancy. So when you talk about nesting and relaxing, progesterone is the mood stabilizer part of the female hormones. It relaxes, it helps with sleep, it helps with sense of wellness sometimes. So both estrogen and progesterone go up very much in the first trimester.
Are women then checked for their progesterone to make sure they have enough, and can they be given more during their pregnancy? Or should
So
they
that's a
be?
great question. If you go on a tangent on infertility, if a woman is having difficulty conceiving, oftentimes it's related to hormonal imbalances. So doctors who specialize in infertility usually know a lot about that. We monitor the female hormones. We look at progesterone through the cycle, whether she does IVF or natural. Once she's pregnant, then the body has a magical way of producing those hormones. So in a normal pregnancy, we don't really need to check because it happens naturally. Now, if a woman has had miscarriages or difficulty keeping a child, then we want to know that before she's pregnant, because oftentimes she's going to need some assistance. But once she's pregnant in a normal pregnancy, 99% of the time, nature takes care of her and does these hormonal shifts to accommodate. The estrogen goes up and the progesterone in the first trimester. That's why the HGH going up. Now there's a phenomenon like morning sickness in some pregnancy. People feel it's directly related to the HGH going up because early in pregnancy, the level of that hormone doubles every day. So if a woman is sensitive, that affects the receptors in the gut and makes her have morning sickness or throwing up.
Now, when a woman conceives very soon after having given birth, like, a month later or something, how does that affect her hormones?
You're talking about after birth?
And after, yeah. Well, I was just thinking, I know we want to talk about postpartum depression, but what if they have babies just, one right after another? Do their hormones have a chance to come down to normal after giving birth before getting pregnant again? Is it like a roller coaster for their hormones?
Well, that varies, obviously, because nursing has something to do with that also. So for women let's kind of zoom into the end of pregnancy and childbirth. Let's say she goes into normal labor and delivers a baby. There's a hormone in the body called oxytocin and prolactin. Those prepare the breast to produce milk. So normally when she delivers the baby, there's a big withdrawal of estrogen and progesterone. Those are the ones that are attributed to the postpartum blues, to postpartum depression from hormonal. There are, of course, psychological factors too, but as we're talking about hormones. However, the body is now prepared. If she is wanting to nurse, then her body will start producing milk. When you have the oxytocin and prolactin at a high level, it's almost like, and most women after childbirth are not going to have intimacy for a period of time, but even if they were, they have almost a natural birth control because it's not very likely that they ovulate. Ovulation is produced in the ovary, and that's related to the shift in estrogen progesterone. So those who do decide to be sexually active after a few weeks or a few months, and if they're not nursing, then you can have someone who every year or so is getting pregnant and having children. In this culture, in this day and age, that's less common than it used to be. But in that case, there is emotional roller coaster and up and down related to the hormones. In the normal postpartum period, there is a drop in hormones, which can explain the mood issues associated, but it also can explain the fact that they don't conceive early until they're... So once she has the first menstrual cycle after giving delivery, that's when it's a signal to the body that conception can happen again. So if she doesn't want to have another baby, she needs to talk to her doctor about birth control. Yeah, nurse or
like
be on contraception,
days.
Exactly.
Now, but I'm thinking about postpartum depression, and I was just wondering if that, having children close together would contribute to that. And why do some women have it more severely than other women?
Great. So let me talk postpartum depression. You're talking about postpartum depression. There are 4 phases, actually. There's postpartum blues, which is very mild, and about 60 to 80% of women, especially first baby, have postpartum blues, and postpartum depression is more severe. I'd say about 20% of women have that. In severe cases, there's a rare instance called postpartum psychosis. That is very worrisome because those are the cases that you hear in the news about where the woman becomes violent or kills her baby or something. Thank God it's rare, but serious. So the doctor needs to watch. So postpartum blues can happen as early as the first and second week after delivery, and it's very mild. Respond usually to support, better sleep, psychosocial support. Postpartum depression is when there is a mood disorder that can happen anywhere from 2 weeks after childbirth to 10 months after childbirth, and is associated with more severe symptoms. It's like depression, but the hormonal component of depression, and that usually needs to be treated. Not necessarily medications. A lot of times supportive therapy, counseling, psychosocial support can be enough. If it's severe, though, we do have medical treatments available for the postpartum depression if it's severe.
How long does it last?
Let me just talk about postpartum psychosis is a medical emergency. The few times in my career that I've been paged by GYNs, it's after childbirth when a woman becomes delusional, psychotic, has distorted thoughts about the baby. That's an emergency. She needs to be admitted and stabilized before any harm happens to her or the baby.
Severe depression, then. Well, how long does these usually last?
Postpartum depression? Well, it varies. So if you have the postpartum blues, which is the mild, that don't last more than 2 to 6 weeks.
When you start getting a little more sleep, it helps.
Sleep has a lot to do with it. Sleep, health, family support, nutrition is really important. Physical activity is important. So if you have the mild case, it gets better naturally in those areas. Postpartum depression may get better, on the other hand, may evolve into other psychiatric symptoms. So with my hat as a neuropsychiatrist, a lot of times I see women who come in with clinical depression later on in life, or bipolar even, where the onset of her first mood disorder followed postpartum depression. So sometimes it doesn't get better, a lot of times it does, with or without treatment.
Okay. What is perimenopause?
So a woman magically between teenage years until late 30s, early 40s has a regular cycle that ends up in ovulation. So there's a shift. So let me talk about a normal cycle in women, before I get to perimenopause, can be anywhere from 25 to 35 days. The shift between estrogen and progesterone is what makes the lining of the uterus build up, ovulation at mid-cycle, and then the shift in progesterone and estrogen is what signals the release of the build-up lining of the uterus, and that's the menstrual blood flow. What happens in perimenopause is there is a diminished production of estrogen and progesterone in the ovary, so that clock goes off, assuming the woman is not on birth control pills or any external hormones, you start having changes in the body which can manifest in one of different ways. It can manifest with irregular periods. Irregular means she was clockwork before, now she is less regular, more blood flow or less blood flow. Any of these can happen. Unpredictable as to when it happens. And if you look at ovulation, there is less likely to have ovulatory cycles, which clinically makes it harder to conceive. So nowadays we have a lot of professional women who delay conception to later in life. The downside is sometimes as the ovaries age, they have less likelihood of productivity of healthy eggs. So perimenopause could manifest with irregularity in menses. Very commonly, hot sweats, night sweats, hot flashes. Those are related to vasomotor symptom changes. Estrogen drop causes women to not tolerate the heat signal very well. The area in the brain is called the hypothalamus. So sometimes one of the early symptoms is hot and cold sweats, night sweats, etc. The third area is sleep. Very often I see people who come in with sleep disorder for the first time around perimenopause. The other area would be libido. Sexual desire drops around perimenopause and certainly menopause, because one of the main libido hormones in women is the testosterone, and which is the male hormone, so to speak, and the primary area of production is the ovary, even though there's a little bit produced in the adrenal gland. Then you have vaginal dryness, which can cause painful relationships, atrophy, etc. later on in life. Then you have moodiness. Very often you start seeing more anxiety, more depression, sometimes worsening of migraines. We didn't talk about that. Migraines are common during the PMS phase. So in perimenopause, they become more severe in that period. And then finally menopause happens, which technically is defined as 12 months after the last period. So perimenopause can be as short as 2 years, as long as 10 years, which is the period of transition in the woman's body between normal clockwork production of hormones to, I call it, going out of business.
Well, then what is postmenopause?
Postmenopause means the woman now doesn't have the protection. So there is, I mean, hormones have a lot of protective factors. Hormones do help with, during menses, women have a protectiveness against heart attacks and strokes. Hormones are protective. Memory is good. So when you go to menopause, you lose all of your internal hormones.
How dare you?
So that's why sometimes people do more natural hormones afterwards, but you don't really, and there was a study, Women's Health Initiative, to look at that. So there are some things that are better. What's better after menopause? If you have migraine tendencies, etc., if you have bad PMS, those are gone once you're in menopause. What the risk would be is you have to be consulting your doctor about whether there's an increased risk in heart attacks or strokes. And of course, in memory later on in life, we know estrogen promotes memory and focus. Sometimes brain fogginess and difficulty with concentration and memory can happen with menopause. And there are, of course, several cancers that increase postmenopausal also.
Well then, but women are given certain hormones after their menopause, are they not?
There's been a big shift in how...
patches and all different
So
kinds
there's
of
a lot.
things.
So I'm telling you, in 2017, we still have to monitor. Some women have mild transition without really major issues.
It's more physical rather than emotional, then, is it?
Well, it's
And
physical, but
postmenopause.
the emotional symptoms are not that severe. Sometimes natural remedies, nutrition, exercise, vitamins. We didn't even talk about vitamins. Vitamins can be tremendously helpful in doing that. So in mild cases, many women don't really need any assistance. I have women who say, gee, you know, I suddenly noticed I don't menstruate anymore without any big... So on the other end of the spectrum, some women have a real horrendous time. So we do use hormones if the symptoms are severe. The big difference now than 20 years ago is most of the time we don't use them on a long-term basis. So we do use them during the transition, few months, a year or two. There are some people who still choose to use hormones after, and they would need to be evaluated by their own doctor to look at risk-benefit analysis, what type of hormones they're using, and what precaution, like breast exams and endometrial. If they have a uterus, there's a higher risk of what's called endometrial cancer. So each woman has to talk to her doctor about that decision. It's very much individualized around perimenopause and menopause as to what she wants to do.
The testosterone, women always have it, but it's not pronounced because the estrogen is overriding it, where when we lose our estrogen, then the testosterone would be more prominent.
So testosterone is always available. If you look at teenage girl or mid-20s, mid-30s, we can test for testosterone, but it doesn't tell us a whole lot. So we only do that if there are hormonal syndromes that we're monitoring. For example, again, we're not talking about that, but a common condition in women, younger women, is called polycystic ovarian syndrome, where she develops obesity and lumpy ovaries. That condition is related to high level of testosterone because the ovaries are not going to ovulate and get rid of the egg, so she has internal ovulation. That woman develops hair on her chin, around her breast, nipples, bikini line. So when a woman presents to a doctor with those symptoms, we investigate hormones because it's unnatural. However, when you look at from a sexual enhancement point of view, if a woman has normal libido through her reproductive years, and now around perimenopause and menopause, she has diminished interest, we do monitor hormone tests. They are done usually blood tests, but there are also some companies that do saliva and other tests. The reliable one medically that we often use is the blood test. But again, I'm not saying the saliva is not. But we can find the levels. And we look at total testosterone and testosterone. So just the figure by itself might not mean much, but you need to monitor. And it will be nice to see what it was before and what it is now. If there's a distinct drop, sometimes we supplement with testosterone in tiny doses.
It wouldn't cause her to be aggressive, would it?
It can. It can. I mean, that's one of the risks. Otherwise, everybody around postmenopause says, hey, give me testosterone. We don't really do a blanket policy with that because there are negative effects. Baldness, losing hair, aggressive behavior, violence, hair growth, thickening of the voice. So there are potentially a lot of side effects with testosterone. So if we do use it, we have to be very careful in what kind we use and how much we use and for how long.
Very fascinating. Thank you for coming in.
Pleasure.
Telling us so much.